Good evening and welcome everyone. My name is Hande Aydınlı. I'm a colorectal surgery fellow at NYU, and I'm one of the new leadership team member. I have the absolute pleasure of introducing Dr. Teresa deBeche-Adams tonight. Dr. deBeche-Adams is the chair of the Department of Colon and Rectal Surgery at AdventHealth Orlando. She has been a staff member since completing her fellowship there in 2011. She earned her medical degree from LSU Health in Shreveport, Louisiana, and completed her general surgery residency at Ochsner Health System in New Orleans, Louisiana. She serves as the director of the Rectal Physiology Lab, and her special interests include TAMIS, TaTME, robotic surgery, pelvic flow disorders. Tonight, she will be talking about functional outcomes, focusing on postoperative sexual dysfunction. Dr. deBeche-Adams, thank you for joining us.
Thank you guys so much for having me. So this talk actually originated as a sexual dysfunction talk. If anybody saw it at Sage's, it was titled "Let's Talk About Sex," and I got the song in my head and couldn't stop singing it. So I'm glad that you guys didn't make me do that again. But here are, let's see if I can make this work, my disclosures. So if we look at the evolution of rectal cancer treatment, at first it was just surgery. And even now we still do that, occasionally, where we'll just take a patient straight to surgery. But along the way, we started thinking, are there better ways to do this? So for a while, it was surgery followed by chemotherapy and radiation, which we know didn't end up very well because we still see some of those patients come in later with horrible effects from the radiation of the anastomosis in their pelvis after surgery. So definitely that's fallen out of favor. And then we started going to this chemo and radiation, and then going to surgery, and then trying to give the patients more chemotherapy after. And we saw with that a lot of patients never made it to that final chemotherapy. And some of them even spent long, periods of time with their diverting ileostomies because of one reason or another, complications from surgery or what have you. So that kind of fell out of favor too. We started moving to this era of like TNT, we give all the chemo and radiation up front. And then once the patient has gone through some of their resting period, then we go to surgery. But then we found that some of those patients responded really well too. So this might even include patients that don't have surgery, some of those that have a complete response and that we go on to do kind of a watch and wait protocol with. So those are included in this cohort too. So going back and remembering some of our anatomy, we all have those organs, memorized, the rectum, the bladder, the prostate, the seminal vesicles, all that kind of stuff. But really, what's more important when we start talking about this kind of stuff is the nerves. So this is your resection specimen here. You've got your Denonvier's fascia and Waldeyr's fascia that we'll talk about a little bit later too. And if you start up at the top, when you're starting to get around the IMA, you've got this inferior mesenteric plexus. And then as you're coming down, getting toward the sacral promontory and going down deeper into the pelvis, you've got the superior hypogastrics. And then the hypogastrics that run down near the TME plane as we get deeper and deeper into the pelvis. Then we've got the nervi argentis on either side. And then anteriorly, we've got the pelvic plexus that includes vessels as well. They injured during the dissection. So of course we want to stay in this holy plane, as Bill Heald called it, taking our nice, chunky specimens with beautiful envelopes, nice shiny envelopes still intact. Everything's all good. We're so happy with it. But what happens to the patients after the surgery? So a lot of them will end up with bowel dysfunction, bladder dysfunction, and sexual dysfunction. And so where they start off with this, oh my God, I'm so happy my cancer's gone. Now they're thinking, God, but my life sucks. Just everything about it is horrible. And so that's what we want to learn about today. So I'd be remiss if I didn't talk about some bowel problems, and namely the low anterior resection syndrome, or LARS. And this is just the disordered bowel function after an LAR, which leads to a detriment in the patient's quality of life. So some of the most common symptoms here are fecal incontinence. This frequency, the patients say, I just have to go so much more than normal. And part of that is due to this clustering or stool fragmentation, where they go like 5 times. They'll tell you I can't leave the house in the morning because I just go, time after time after time after time. And it's a whole process before I can actually even get out of the house. So just looking at some more of these symptoms, they've got this variable, unpredictable bowel function. They can even have just trouble emptying because of some of the nerve and muscle dysfunction. Their stool consistency is maybe a little bit different. They've got to rush to the bathroom because they can't hold things very well. And with that increased frequency can lead to some incontinence, some soiling, and then they just go so many times, and sometimes that can be really painful to them. So what are the consequences of that? They'll tell you all the time, gosh, I walk into a store or a restaurant, I know where every bathroom is. That's all I think about every day. I've got a set of extra, clothes with me, some panties and shorts or whatever that I carry around in a bag in the car, everywhere I go. They're really not happy with what's going on with their bowels. And they start to come up with these coping mechanisms for it. But it really has a huge impact on their mental and emotional well-being. You'll see that they sometimes get really, really depressed because they can't take part in some of their normal like social activities. Their intimacy is, of course, affected by this. And then anything else, their job or any other things that they do outside of the house really becomes affected by their bowel function. So where does this come from? It's still kind of poorly understood. Some of it is that loss of the rectal reservoir. We make the rectum smaller, and so they just can't hold as much. And then, of course, we know that we affect the nerves as we get down deeper and do our pelvic dissection. And then the colonic motility is increased. So I tell patients sometimes, we went from having this nice sigmoid colon that, came in as like a holding pattern before it got to your rectum, and now it's just like a straight water slide. It's just, from the splenic flexure down, it just goes straight down to your rectum. So that, along with some decreased anal resting pressure, can definitely lead to some of the issues. And then, of course, radiation. So we know they get some significant burn to those nerves there and some scarring that happens in the pelvis. And so that can definitely contribute as well. And what are some of the risk factors? So, looking at it, they probably say that the incidence of major LARS is about 40 to 50%. It's probably a lot higher than that. And we need to do a better job at capturing those patients because overall it's probably up to about 70%. Females are a little bit more affected than males are. Tumor location, right? So if we go deeper and deeper into the pelvis, lower, our extent of surgery is lower, then those patients are going to have more dysfunction. And then, as we said before, the radiation. And then patients who have had fecal diversion, so those that had a loop ileostomy and kind of weren't using their equipment for a while, may have more bowel dysfunction after surgery, after that reversal. So here's the LARS scoring system. And this just helps us to kind of stratify the severity for the patients. And this can be given to them whenever they come back to the office for any of their follow-up. So basically, any score below 20, they don't really have LARS. Anything above 20 is kind of minor, but then above 30 is considered major LARS. So does radiation, kind of the way we deliver it, does it have anything to do with that too? So looking at short course versus long course radiation in those mid to low rectal cancers, and looking at the incontinence score 6 months after surgery, that actually long course had 90% fecal incontinence rates compared to 55% with short course. So we do see more problems with long course radiation. And then what about if we have a surgical complication, right? We have a leak or something else happens. This was a retrospective study looking back at over 1,000 patients, and those that had anastomotic leaks, 67% of them developed LARS compared to the patients with no leaks that were less than 50%. So when you talk about the treatment of this, you have to explain to the patients that it is a very challenging problem, that they have to have some patience, and we give them lots of reassurance that we can definitely help them. I coach my patients and I tell them even before surgery that they need to tell me what's going on so that I can actually help them with it. If I don't know that it's happening, then I can't help them. So we can coach them through it, but they've got to be willing to let us know what's happening. And then, like I said, too, close follow-up. So if we don't know, we don't see the patient don't see them back and ask them what's going on, then they're going to suffer in silence. And what are some of our treatment strategies? This is a beautiful algorithm that goes over kind of all of this stuff. And if we look on the left-hand side first and look at those minor Lars patients, especially the ones that are like diarrhea predominant, we can start with some medications. So we do Imodium and Lomotil to try to just slow down the bowels. And then some other bulking agents like psyllium fiber and Fibercon, which is one of my big favorites. The patients that are more prone to like incontinence or urgency, using some serotonin 3 receptor antagonists, the easiest one for us to get is something like Zofran, can actually help along the way too, in addition to some of those antidiarrheals and bulking agents that we had the other patients on. So then if we go to the right side and look at the major Lars, I think two things that really kind of get lost in the grand scheme of things are using things like transanal irrigation and pelvic floor rehab. So the transanal irrigation can really just start simply with some enemas, and the patients are taught to do those typically after they have their first bowel movement, and I tell them it's to kind of flush out everything that's left, and that can really help them manage everything. If they do well with that, then there are systems that they can take home that actually have everything for transanal irrigation to do larger volume irrigations, and that can help out quite a bit too. We're big believers in pelvic floor rehab. We have such a big pelvic floor unit here, and they really help our patients out. And it's not just for the little old ladies that come in, that had 10 kids, but some of these patients with Lars do really, really well with our PT. Sacral nerve stimulation is also something that can help if you find that the patients will qualify for it. And then we never like to talk about it, but sometimes if the patient's quality of life is really suffering, the best thing to do is just to transition them to a permanent stoma, and they'll likely have a much, much better quality of life. And so that will help out quite a bit. So let's go on to some of the urinary and sexual dysfunction stuff. So unlike patients with prostate cancer, the men that have colorectal cancer are usually not routinely offered any information about erectile dysfunction. And so 50% of them even recalled somebody talking about it, and 18% of females have even heard anything about it too. So the females, I think, are never really talked about in this group of patients. So more than 50% of those also wish that somebody would have talked to them. So the need is there. We just need to address it. So the findings demonstrate that rectal cancer patients have this sexual dysfunction and really want to talk to their physicians on the topic, but there are some gender differences along with that whenever we talk about the post-op counseling. So some of the risk factors for this: multimodal therapy, so radiation and chemo, plus surgery. Age, we know, is a big deal. Tumors below the peritoneal reflection, like we talked about, the deeper and deeper we get into the pelvis. Radiation, again, extensive surgery, things like APRs, intersphincteric dissection, really kind of increase their incidence. And then, as I said before, the female sex is higher with this as well. So looking at some of the urogenital dysfunction, this is a nice study where they looked at patients before treatment, after radiation, 3 months, 6 months, 12 months, and you can see that their dysfunction before surgery, some of them probably did have some prior, and then after radiation, it can drop off. It definitely takes a big drop after surgery, but they do rise up a little bit again with time. Here again, we got our baseline status in red, and you can see that the sexual activity, normal erection, and ejaculation definitely drop off 12 months after surgery. So those are big affected things. And then with this other stuff, this is with females, things like dyspareunia, sexual arousal, satisfaction. You can see how much they drop off, mainly at 3 to 6 months after surgery, and some of them increase a little bit after 12 months. So again, those low rectal tumors increase the risk of that, and early detection of these patients using some of these standardized questionnaires and stuff would probably be a good idea to try to capture them better. So this is a nice graphic just showing where the nerves can be injured and then what the urinary and sexual consequences are for those injuries. So like we talked about before, some of the sympathetic nerves will definitely lead to some stress, urinary incontinence, and retrograde ejaculation. The hypogastrics during that posterior dissection can also lead to alterations in ejaculation. The splanchnic or parasympathetic nerves, sorry, I got a little bug, can lead to some neurogenic bladder symptoms. And men can have alterations in their erections, and women can have dyspareunia from this. And then during our lateral dissection, we can also contribute to incontinence, difficulty voiding as far as bladder problems, and then problems with ejaculation and erection for male patients. So how about during our IMA dissection? We always talk about doing a high ligation so that we can get as many lymph nodes as possible, but we do know that this can contribute to some nerve damage. So the low IMA ligation actually scores a little better in terms of fecal incontinence, less abdominal pain, and then less genital urinary and sexual dysfunction. So how about our approach? Initially we talked about lap versus open, no difference here. And another group looking at it, the sexual function was maintained in 51% in the lap group and 49% in the open group, so pretty similar numbers there. And then this is a meta-analysis of over 800 patients looking at the post-op ejaculatory dysfunction and erectile dysfunction. And the rate of overall sexual dysfunction was pretty similar in both groups. And in women, they also saw no difference. So how about our cameras? 2D versus 3D. There's actually quite a bit of difference here. So in the 3D group, only 8% had significant dysfunction, and in the 2D group is over 40%. So this was a pretty big difference. So we definitely need to be able to see well, right? I think that's the really the take home here, is that the better we see, the more nerves that we can leave intact. So then the robot comes into play. And we can see here that from baseline to 3 months after surgery, it does favor the robot. And even at 6 months, it still favors the robot. So the robot may be a little bit better. And maybe in terms of, again, being able to see better, just having better visualization of those nerves so that we avoid more injury there. So this one had 6 studies with nearly 400 patients in the robotic group and a little over 400 in the lab group. Sexual functions better at 3 months in the robot group, but not significantly different at 6 and 12 months. And that may go along with some of the earlier studies I showed, where some of the patients do regain some of their function at 6 and 12 months. So TaTME, we do a lot of this here, and I wanted to look at this and see if we contribute to anything. But actually, it's maybe a little bit better, at least not worse. So it doesn't change bowel and urologic function. Maybe some trend toward better erectile function with the TaTME group. This study just looked at male interest in intercourse, very decreased at 1 month. I don't think anybody's ready to do anything at 1 month post-op, but returns to the same level as before surgery at 6 months. The erection problems didn't significantly increase after surgery. And only 2 patients that were female answered the question about sexual interest, and none of them answered about dyspareunia. So again, this is kind of a lost patient population. We need to really address some of the females in the group. So how about a take it or leave it? Denonvier's fascia. If we leave it, we have a lower incidence of ejaculatory dysfunction at 3 months and at 6 months. And at 12 months. So pretty big difference here. And then something that's gaining more traction lately too, the lateral pelvic lymph node dissection. This significantly increases the incidence of male sexual dysfunction compared to standard standard TME. And just probably has to do with, of course, getting further laterally into some of those nerve groups and causing more dysfunction. So then what about those patients that maybe almost fall in the watch and wait? or we want to do an excision after radiotherapy. These patients can still have some issues, but it's significantly better compared to the patients who had an LAR. And they claim that their health status caused any worsening of their sexual function. So they did have a little bit, and the impact of this didn't differ between the female patients. So again, people are starting to ask their female patients and include them in some of these discussion, but we're showing that that doesn't contribute very much. Now, what about a stoma? Some of our patients need it. They have an APR. Some of them get it temporarily with the DLI. And how does that affect their sexual function? So there's really 6 themes that emerged from this study. A lot of them had loss of or decreased sexual activity, psychological issues with this, physical issues. So think about like if their bag, comes off, or they have a leak during any kind of intimacy, that's really going to put a damper on everything. Some of them talked about some partner rejection, and definitely some interference with the stoma during this. Occasionally, some of them had some positive experiences. I don't want to know about that. I'm not going to ask, but I'm very happy for them. That's all I can say. So like I said, these female patients, we kind of lose them in the talks of all of this, but it does need to be discussed with them. Even just after pre-op radiation, they can have significant impairment in sexual function, and needs to be discussed and also considered whenever we talk to young patients, because some of them can be put into menopause from the radiation as well. And as far as some of their dysfunction after, of course, the pre-op radiotherapy was strongly associated with this in terms of the vaginal dimensions, so it can cause some atrophy there, dyspareunia, lack of desire, and sexual inactivity. No statistically significant difference between short and long course radiation. And then their bowel dysfunction is also negatively associated with some of their sexual desire, activity, satisfaction, and this could probably be due to some LARS and fecal incontinence. So really what we need to discuss here is that we need to talk to patients because it does affect their physical and psychological well-being. The discussion needs to begin prior to the initiation of treatment and definitely continue throughout the treatment and survivorship. So we have to have that follow-up with the patients so that, like I said, we know what's going on and can actually help them with it. Because if we don't know, we can't help them. But that talk needs to start before we even begin any radiation or chemotherapy or go straight to surgery. Before anything, we really need to discuss with them the potentials of things that could happen, and then how we can address them as those issues come up. So really, like I said, in conclusion, talk to your patients before, during, and after treatment. Set some expectations with them. Tell them, yes, you may have some of this, and occasionally it will get better with time, but I can't totally promise you anything, and we'll just work with you as things come up. Get them the help that they need, whatever that might be. If that's training them how to do enemas, how to do transanal irrigation, if that's sending them to pelvic floor PT, if that's just having dietary changes with them or starting a little bit of Imodium, you really just need to be aware of what's going on and then lead them in the right direction. We know that more precise surgery is better for nerve preservation. So however you can do that, whatever that means to you, if that's robotic, if that's TaTME, however you feel that's best in your hands. But we know that we need to preserve those nerves better to retain their function. And then also consider local excision for some patients. We're even doing, some local excision, and then if the biopsy comes back a little bit, deeper than we thought it would be, that we're maybe giving some radiation and chemotherapy after. But maybe with this shift toward organ preservation, we can see maybe some slightly better numbers with some of the dysfunction in terms of the sexual and urinary stuff. And then too, like Lars syndrome, if we can retain the rectum. So again, like I said, talk to your patients. Really, I think the communication with that is the biggest takeaway. So I want to thank you guys again for having me tonight.
Thank you so much. This was a great lecture. It is a very important topic, but most of the time it's really overlooked, both by the patients maybe prior to operation or the treatment, and by the providers too. I wanted to ask you, start the question sessions. Anyone who wants to ask a question can post it on chat, or from Surgeon the same way from the chat too. I want to start asking about the pelvic floor rehabilitation that you provide for Lars. Can you tell us a little bit more about the length of the treatment and what are the expected outcomes? And
Yeah, so like I said, we have a large physical therapy unit here. And so when we send the patients, because they are a little bit different than some of our patients who haven't had operations like this before, I usually get in touch with the PT first and let them know kind of what the patient's experiencing and what I want them to focus on. But they do a lot, even just with the emptying, like with Lars syndrome, they can have a lot of, dyssynergia and stuff. And so they may need to learn how to use those muscles again. And so it may be some biofeedback and things like that, or some strengthening exercises if they're having more fecal incontinence episodes. So I try to let the PTs know before they come in, exactly what's going on. And I think that helps. But as far as like the length of treatment and stuff, I think a lot of it depends on their insurance. Usually we see that either they cover like a certain number of visits or they cover a certain amount of time. And so I tell the patients, just try to get the most out of it. If it's only a certain number of visits, do them, really jump in there and get them all done. But if it's a certain amount of time, maybe they stretch them out, a little bit if they can. And so our PTs are always willing to see them back too. So if they do good for a while and then they need a bit of a refresher, say in a year or so, they're happy to see them back again there.
Great, thank you. Susie Hill is asking, can you talk a little bit more about your success with SNS for patients for Lars? Specifically, what time frame do you start offering this as well?
Yeah, we haven't had too many patients that have made it all the way there. Usually I would say after about a year or so of, kind of going with all the other treatments that we do, that maybe we say, yeah, this patient might benefit from it. But I definitely think we give them a good amount of time to try without it, even though it's pretty minimally invasive, it's not a big surgery or anything, but we definitely try to avoid it if we can with some of those more conservative measures first.
Great. We have another question. Any suggestions on how to ask questions about sexual dysfunction with patients pre-op and post-op?
So it can always be kind of awkward, right? I mean, we do all this stuff and joke with patients that I see butts all day and every day, but we can't ask them, whether or not they can get an erection. So yeah, I think sometimes I'll make a little bit of a joke about it. Ask the patient, are they still having fun with their partner or something like that? And it breaks the ice a little bit and then they can talk about it. And then I'll tell them too, I'm going to ask you about this after because I want to know how it's going after. And so they're already kind of prepared for it and can talk about it. We have some really good urologists too, especially if they have urinary dysfunction, that are very quick to see the patients as well. So I think that's a little easier to talk about. It is the sexual dysfunction that's not. So yeah, I think just trying to do something, to break the ice at the beginning. And then, tell them that it's going to be an issue. We're going to keep talking about this as we go.
Great. And we have one more question here. What are the available treatments for female patients who do complain of sexual dysfunction or dyspareunia after proctectomy?
So this is really tough, especially if, they have a lot of scarring in their vagina and stuff after surgery, because that's generally where most of that comes from. There's some use of vaginal estrogens, which can help, and dilators. And sometimes using these like in combination, because the estrogen can soften the tissue some. So doing things like that can sometimes help. Again, pelvic floor PT is great for this. And so we'll send a lot of our patients there as well. And they can even teach them how to do the dilators and things like that. So we generally use them as well.
And I have one more question. When you talk about the radiation effects with the patients pre-op, do you usually are the person who explains or discusses the colorectal surgeon, or do you get the surgical, radiation oncologist on board for this?
Yeah, so I do touch on it. I don't go into giant detail because our radiation oncologist will usually discuss all of that with them. But I do touch on it because I want them to know about it. And by the time they get to the rad onc, I want them to, if they've thought about some questions or something, I want them to already know that that's a possibility. And so they can, make those questions before they get to the rad onc appointment.
Awesome. Thank you so much. I don't see any other questions on chat or Surgeon. This was a great lecture. Thank you for joining us tonight.
Thank you guys. Y'all have a good night.
You too.
Thank you.